Good afternoon. Welcome to TCTAP 2022 Satellite Symposium sponsored by Boston Scientific. I'm Young Ko from Severance Hospital, Seoul, Korea. The title of this session is Recent Updates on Peripheral Vascular Management with Diverse Technologies. It's my great pleasure to chair this session. My co-chair is Dr. Seung-Hoon Ra. Dr. Ra, could you say hello to the audience?
Hi, I'm Dr. Ra, working at Korea University Goro Hospital. I'm happy to join this session and will co-moderate with Professor Ko. Dr. Ko will introduce the first presentation, and I will share the last two presentations. Let's share the three presentations and discuss together.
So in this session, we have three presentations, and after the three presentations, we'll have the discussions together. And we have very well-known panelists, Dr. Osamu Ida from Japan, and we have Dr. Brian Yang from Hong Kong. Welcome. So I'd like to introduce the first speaker, who is Dr. Chang-Wan Yoon, who will talk about economical value and impact of polymer-coated paclitaxel-eluting stent Eluvia. Dr. Yoon, please.
Good afternoon, ladies and gentlemen. I'm Chang-Wan Yoon, working at Seoul National University Bundang Hospital. Today, I will talk about recent clinical studies regarding Eluvia stent and its economical value and impact. Timing of SFA restenosis is longer than coronary stenting, which is predominantly occurs within 6 months after stenting. Factors for restenosis in the SFA include the number of run-up vessels, severity of lower limb ischemia, and length of disease segments. Therefore, the Eluvia stent system was designed to sustain drug release through 1 year when restenosis is most likely to occur. In contrast to Gilbert BTX, which released the drugs within 2 months. Eluvia is based on Innova stent platform, which has excellent radial strength, flexibility, and fracture resistance, and thus it provides a uniform scaffolding for optimal drug delivery. Eluvia coating design is similar to the coronary stents of Boston Scientific. The metal was covered by PBMA as a primer layer, which promotes adhesion of active layer to stent. And then there is the active layer, PVDF-HFP, which is a polymer and controls release of paclitaxel, like the coronary stent. This is Eluvia DS RCT results at a glance. Eminent study compared Eluvia DS with BMS and showed a significant better primary patency at 1 year, and then has been following the results up through 5 years. Imperial study compared Eluvia DS with Gilbert PTX and reported a significant better primary patency at 1 year and less intervention rate at 2 years. Imperial study has been also following up the result through 5 years. Its efficacy is durable and consistent across real-world studies as shown here. Majestic first-ever first-in-man data demonstrating exceptional 1-year primary patency, 96.4%. In addition, Minster Registry, Auckland Orcomer Registry, Desafinado Registry also showed excellent results despite of long lesion length and a higher rate of occlusion. From now on, I look more into the two studies, Eminent and Imperial. Eminent is the largest randomized controlled trial comparing Eluvia drug-eluting vascular stent system to self-expanding bare metal stent for SFA or palmitoral artery. In summary, Iluvia DS demonstrated superior effectiveness over BMS at 1 year and a statistically significantly greater rate of primary sustained clinical improvement without re-intervention. In detail, the eminent study was designed to confirm the superior patency of the Iluvia drug-eluting stent compared with bare metal stents for the treatment of superficial femoral artery and or proximal palmatory artery lesion. The primary endpoint was primary patency at 1 year, and the trial involved 58 centers in 10 European countries and is the largest industry-sponsored randomized trial of drug-eluting stents for SFA or palmatory artery. The eminent study included 775 patients randomized 2-to-1 to treatment with the Iluvia drug-eluting stent or bare metal stents, which are comprised with these results. These stents. Inclusion criteria of the eminent study is SFA disease with Rutherford category 2, 3, 4, when degree of stenosis over 70%, and vessel diameter over 4 millimeter and below 6 millimeter, and total lesion length is over 30 millimeter and below 210 millimeter. Baseline characteristics of the patients were well balanced between the both group, and total lesion length was 75.6 millimeter and 72.2 millimeter. And moderate calcified or severely calcified was 21 to 30% at each group. The Kaplan-Meier analysis showed a significant improved maintenance of primary patency through 1 year for patients treated with Iluvia, with log-rank p-value was 0.0087, very significant. And in eminent, primary sustained clinical improvement was defined as an improvement by at least one Rutherford category without target lesion revascularization, and significantly greater proportion of patients in the Iluvia group than in the BMS group showed primary sustained clinical improvement without re-intervention. Regarding the safety data, no significant difference were observed in major adverse events through 1 year, and the major amputation rate was very low, with just one reported in the study. And 12-month all-cause mortality did not differ significantly between patients treated with the Iluvia paclitaxel-eluting stent versus BMS. In conclusion, Iluvia demonstrated superior effectiveness in terms of primary patency through 1 year and sustained clinical improvement over BMS through 1 year. At the same time, there was no significant difference in CEC adjudicated major adverse events rate. Now, let me talk about the Imperial study. Imperial is the world's first head-to-head DS SFA trial. It is a global randomized controlled multi-center trial with 2-to-1 randomization of the Iluvia drug-eluting stent against Cook Medical's Gilbo PTX stent. Imperial study contains long lesion subset study and the pharmacokinetic sub-study. In 65 centers, a total of 465 patients were enrolled. This is a table demonstrating the difference of the study stents. Iluvia has a polymer compared to the no polymer, and the paclitaxel dose was lower than the Gilbo PTX. Iluvia showed statistically significant primary patency 92.1% at 1 year compared to 81.8% in Gilbo PTX. Iluvia also achieved the highest primary patency reported in any SFA pivotal trial at 1 year. Iluvia also showed better primary patency rate at 2 years, 83 versus 77.1%. And the durable, consistent results were also shown in complex lesions, such as lung lesion and diabetic subgroups, and severe or moderate calcium group, and also CTO subgroup at 2 years. This is a summary of drug-eluting device data in terms of Kaplan-Meier primary patency at 2 years, Ranger DCB in Ranger SFA second study, and Iluvia in Imperial study showed the best 2-year primary patency rate compared to the previous studies with various devices like JBPTX, Illuminate, Compare, or Levant trials. And as you see, the long lesion study 2-year patents was 77.2% in Iluvia stent. If you compare this result with the rapid trial, the rapid trial consists of Supera stent treatment or Supera plus DCB treatment. And the 2-year primary patency is 48% or 55%. So better primary patency in the Imperial study, long lesion study. The long lesion length was similar between the study. And it also showed low repeated intervention at 2 years. 2-year clinically driven TRR was less in Iluvia stent. It was statistically significant. And Iluvia demonstrated consistent low CDTR at 2 years in challenging SFA region, like diabetic or calcium, CTO, long lesion, such as things. And all-cause mortality at 2 years was within the range expected for symptomatic PAD, and no difference was observed between both therapies. So no issue about the mortality. So in conclusion, at 1 and 2 years, Iluvia DS demonstrates remarkable long-term durable in patients with complex SFA regions. And it also showed superiority over GilboPTX. It was significant. So now let me talk about the economic impact of these results. And in Korea, Korean National Health Insurance Service is very stubborn, and it sets low price and too much quality-related request. For example, artificial arterial graft of Gower, they faced this stubborn attitude and they retreated from Korean market. So this is news about the baby who could not undergo cardiac surgery because of the Gower retreat. So our insurance service is very stubborn, but in Boston Scientific Group, they tried to persuade the Korean insurance service regarding the economic issue, and they appealed the data. With this data, the 5-year budget impact analysis they performed, and they proved that if they use the Iluvia stent compared to the GilboPTX, they can get the better economic value. So, for example, Iluvia compared to GilboPTX, it reduced the cost as a total. So, approving this result, our stubborn health insurance service set the Iluvia device cost more than the GilboPTX. So this is very interesting and astonishing to me because they didn't try these things before. So maybe they acknowledge the economic value of the better clinical outcome, and they tried these things. But anyway, the Illuvia drug-eluting vascular system is a new standard of care in SFA stenting, and no SFA stent has performed better at 2 years, and it showed better primary patency at 1 year over BMS, even GIVO-PTX, and Illuvia demonstrates the statistically significant fewer repeat procedures compared to GIVO-PTX. Thank you for your attention. This is the end of my presentation.
Okay, Dr. Ra, could you proceed with the next presentations?
Thank you for good presentation. I'd like to introduce the second presentation. Professor Chulminan from Severance Yonsei University Severance Hospital in Seoul, Korea. His title will be Recent Experience on Clone Management with Angioid thrombectomy System.
Actually, the topic was a little changes. So this time I talk about leave nothing behind with the atherectomy with a jet stream from the request of the TCTAP. So Dr. Professor Yoon has already said about the DES for femoral popliteal lesion. However, you know that the femoral popliteal artery had a unique anatomy and biomechanics for any kinking and compression and fixed, and then so high prevalence of diffuse calcified thrombotic lesion and another variable mechanical forces can make some deformity of the devices in the inside of the femoral popliteal artery. So atherectomy and anti-stenotic treatment was a little valuable for some the long and calcified lesion, especially the drug coating balloon was had some continuously recurred for some longer lesion and calcified lesions. So some rotational and directional atherectomy can be a candidate for another option for lesions. And calcium itself has an impact of some outcomes of after some peripheral angioplasty in femoral popliteal. So it's another issue was calcium make a more complication, some peri-procedural area. So we should calcium is not a benign, so we should take into the account for the procedure. And many devices was used although widely. However, some nations and directional and rotational jet stream and Rotarex was available for the peripheral angioplasty. And rotational atherectomy of jet stream was some unique some characteristic of front cuttings of some atheroma and the differential cutting because some only cuts of elastic tissues, and also had a function of active aspiration and make a concentric lumen. And it had 4 kinds of devices. Only 2 kinds was expandable mode, and 2 kinds was a single cutting mode. So we can make a choice for some variable lesions. And jet stream had a luminal shaping was more some concentric, and it also had some function for some instant lead stenosis, and some region of BTK. It had some uses. Small and many studies was published for some efficacy of jet stream, and then pathway PVD shows 74% of TLR free at the 12 months, and jet stream calcium study shows 26 patient as responsible for 86% of lumen increases, and jet registry also had over the 80% of TLR and TVR free 12 months. Jet SC compare the jet stream plus DCB versus jet stream plus angioplasty of 75 patient. It has also some outcome of jet stream plus DCB had a more effect. It concludes for some jet stream had a more some impact of a drug effect of after the jet stream. And long-term outcome shows also in compared to 12 months, the 24 months of TLR was much improved for the atherectomy some group. So atherectomy itself has a more sustained effect over femoral popliteal lesion. And our data also shows 115 patients for some atherectomy plus DCB and atherectomy plus POVA. So in the drug coating balloon group has more some good outcome compared to just angioplasty. And then the some hazard ratio was higher in ISL, and then DCB use after the atherectomy has more good outcome compared to some conventional angioplasty. And then Professor Ida group had some published for some the J-SPRIM and J-SPRIM2 trial, and J-SPRIM had some for some the jet stream plus angioplasty. It's concluded for procedural safety and efficacy, and J-SPRIM2 is a jet stream plus DCB. It's more maintenance after that compared to the previous group. So you can see that the J-SPRIM has a 50 patient has a very good 6 months outcome, and plus the jet stream plus DCB has more improved in primary patency. And the Jet Ranger clinical study has a more larger study for jet stream plus DCB versus PTA plus DCB. It's a 2-to-1 randomization. I think its enrolled was completed in the late in 2022, so we can expect for some more good data. I recommended for some usually for beginner rotational atherectomy. A very slow advancement was very important, and then intermittent cool down and some prevention of wire stocking was very some cautious for some the advancement of devices. And usually we use distal protection devices and some kind of a stiff aortic bifurcation. It can be some difficult to transfer. And then don't use intrastent because the intrastent structure can be disrupted for some atherectomy devices. It's my case is 67 female with a very diffuse Koch-file lesion, longer lesion. So after the wiring, the jet stream was used for some atherectomy first, and then balloon and then DCB was performed, and then final outcome was very good without the significant dissection. Another was an 84-year-old male with a cloud count. The bunker, both ankle block index was less than 7. So it's left side was very diffuse diseases. And after the selection of a superficial femoral artery, we make a good intraluminal tracking by the extravascular ultrasound. And then after the wiring, so we check the IVUS and then the status of the wire, some stay in the intraluminal space. Some portion had a little eccentric, but generally it's a wide, well penetrated intraluminal pathway. So we make a atherectomy first for the diffuse region, and then initially it's a very good luminal gaining, and then we make a balloon and some drug coating balloons for some the long region. There are some minor dissections in the inside of the some mid SFA, and proximal had some more larger some dissection at there. So in some cases we needed some bailout stenting for some dissection coverage. But after the coverage, the outcome make a good result, and ankle-Baraka index was much improved on the left side. So my recent strategy for some the femoral popliteal device selection, so well penetrated without any resistance, I considered the thrombectomy device first, and had there are some minor resistance of the wiring, we selected some arteriotomy devices, and then make a good wiring. We use some sono guided, some EVOS guided wiring, true lumen wiring, and then we make angioplasty and drug coating balloon is routine. But if there are some dissection, we make some standing at there. So complex femoral popliteal region still some remain challenging for and then region characteristic should be considered for selection of a proper arteriotomy. And then JetStream is a logical treatment strategy for use in long and complex and calcified lesion for some effective immediate procedural success and maintenance of patency. Thank you for kind attention.
One message. Last presentation will be given by the Professor Min-gu Chun, working at Busan National University, Yangsan Hospital. The title will be The Role of IVUS in Peripheral Intervention. Okay, please.
Thank you, Chairman. Good afternoon, ladies and gentlemen. My name is Min-gu Chun from Busan National University Yangsan Hospital. Today, I'm talking about the role of IVUS in peripheral intervention. IVUS was introduced at the 1980s and upgraded in catheter deliverability and image quality. Nowadays, IVUS used widely in coronary field, and several devices are available in the market. This device has some good point as measure accurate vessel size and determined plaque composition, especially calcium, and locate anatomical landmark and contrast reduction and look for unseen issues such as dissections and so on. On the other hand, there are some weak points, mainly the device is expensive and need additional procedure time. As I mentioned, the use of IVUS become a standard imaging technique based on the good result of several studies. But most of this use is relegated to the coronary intervention. This is the last year data of IVUS use in coronary intervention in our hospital. As you see, using IVUS in coronary artery was about 92%. However, in peripheral intervention, is only 5% of procedure was used IVUS. If so, angiography alone is enough for peripheral intervention. In this angiogram, there is no significant stenosis. But change the angle, you can find the significant stenosis on femoral artery. In my opinion, conventional angiography provides a single plane shadow of the vascular lumen. It has limited ability to measure vessel stenosis accurately and characterize plaque morphology. What is viewpoint of IVUS in peripheral intervention? Proper sizing or accurate analysis of a vessel? Let me show. In BIPA trial, we can find why size is important. BIPA trial is a study to evaluate the performance of Bioban in treating long segment SFA. The result of BIPA trial showed more than 20% oversized stenting group was significantly poor patency in 12 months. And multiple studies have demonstrated that stents that are oversized or undersized have higher rates of restenosis. So adequate size is important for good result. Code trial was comparison of assess calcium pattern of IVUS versus angiography and correlated calcium severity and midterm clinical outcomes in 102 cases. In the result, severely calcified lesion, the extent more than 180 degrees in IVUS had a highest instance of restenosis. This modality should be used to accurately evaluate calcification severity. And in statistical association was demonstrated between the severity of calcification assessed by IVUS and the patency rate. On the other hand, Peripheral atrial calcium scoring system, PACSS, grade evaluated by fluoroscopy or angiography alone was not significantly different among the groups. Angiography could not accurately predict poor outcomes related to calcification. In short, accurate assessment of calcification related to good result. Dr. Ida and colleagues reported comparison of primary patency rate of IVUS versus non-IVUS guided procedure in 234 propensity score matched pairs. The study showed IVUS use was associated with significantly higher primary patency rate than non-IVUS use. So IVUS guided procedure related to good result. Unfortunately, recently in meta-analysis, the use of IVUS did not show significant difference in primary patency. However, the study had limitations such as including observational studies, heterogeneity, and small numbers. A recently small single-center RCT shows notable result. As you can see, the study shows significant reduction in the rate of restenosis after after endovascular intervention on femoral pulmonary artery with the IVUS. IVUS use in peripheral intervention has potential to improve outcomes. What is another role of IVUS in peripheral intervention? Says differential diagnosis of failing defects or angiographic abnormalities, and the confirmation of intraluminal wiring and checking the lesion characteristics to aid the choice of atherectomy. IVUS guided CTO intervention and even in venous interventions such as metanol stenting. Let me show some cases. First case is a 69 years old male. He complained to light pelvic pain and claudication. His ABI was 0.67 in right. As you can see in this angiogram, right common iliac artery was total occlusion with calcification and a small stump. We tried bilateral approach and lateral wire movement guided and confirmed by real-time IVUS. After the several trial, we could cross the lesion. After the closed lesion, we checked IBUS. We could confirm that all closed lesion was intraluminal. And then pre-balloon was done and 8mm state was deployed. This is final angiogram. It's good result. Second case was 56 years old male. He has DM and hypertension. He complained left claudication. Initial angiography shows significant stenosis in the left SFA. After the wire crossing, we checked the IBUS for confirmation of intraluminal wiring and checked the lesion characteristics to aid in choice of atherectomy. IBUS showed fibrofatty lesion with a massive plaque, and we confirmed that the lesion was needed debulking. Rotational atherectomy with jet stream was done. And this is result of atherectomy. We got the adequate size of the lesion from IBUS, used a 5mm size DCB on the lesion. After the DCB on SFA, we could get a good result. Okay, in conclusion, IBUS is superior in vessel size, assessing anatomy, plaque characteristics, and adequacy of interventional result. IBUS also aid other procedures such as CTO and atherectomy. And IBUS use has potential to improve outcomes. However, large and long-term RCT is needed to determine the routine utilization of IBUS in peripheral artery intervention will result in improved outcomes and whether routine application of this technique is cost-effective. Thank you for your attention. Thank you.
Thank you very much. So the topics are open to discussion. Dr. Ida or Dr. Yan, do you have any comments on the topics presented today?
Thank you for the three speakers, three very excellent talks. Obviously, three different modalities. I mean, the one questions I have is they all have shown clinical efficacy, but I think the question people mention is the cost effectiveness of it. I mean, to Dr. Yoon, I mean, do you think what's the can you calculate some sort of incremental cost that you could that will require from say bare metal stent or drug-eluting stent to prevent re-intervention? Because most of the time when we look at health economics, we look at sort of the incremental costs. And I guess similarly maybe to IVUS as well, because I think Japan, maybe Korea is very lucky that IVUS is reimbursed, so you can use it freely. But some countries like maybe Hong Kong or other America, Europe is not. So you probably see even in coronary intervention, you don't use as much. So I think you're right that it's very important for us to demonstrate the cost effectiveness of the equipment, and also I mean for data as well. Again, the incremental cost is quite high compared to standard therapy, but I guess so far the trials, I mean, haven't demonstrated that the cost effectiveness. Do you have any data to show the cost effectiveness of all these three different strategies, which are effective? I agree.
Okay, let me talk about the cost effectiveness first. I had a chance to review the cost effectiveness of drug-eluting devices and also bare metal stent in a previous conference. And I reviewed the data and I found that the peripheral artery devices, intervention devices, very not cost effective, especially the bare metal stent. You should not use it, because it is not cost effective. It doesn't have any quality. This is a kind of a marker of cost effectiveness. It's very poor quality. But drug coating balloon if we use 1 or 2 drug-coated balloon in the one intervention, there is cost effectiveness. And regarding the drug eluting stent, and this is more expensive one, and then there was a marginal cost effectiveness. But the Illuvia stent showed better result at 1 year primary patency and 2 year CVRF. So maybe we need to recalculate it. And the last slide I showed is the extrapolation of the Imperial study or the eminent study to the Korean situation, and they proved the quality if we use the Illuvia stent, and that's why the Korean insurance service set a higher cost for the Illuvia stent than the Silver PTX. But anyway, we needed to check it. This quality usually measure the cost effectiveness in the one device, but in the long region we use the many devices there, and if the region length is longer, there is a higher chance of restenosis or reintervention. So I guess that there is no cost effectiveness of the drug eluting devices. And the DART, it's very poor. In Korea, if we perform the DART compared to the POBA, maybe 20 times or 30 times higher cost for the intervention. So I don't think it's cost effectiveness.
Yeah, it is very difficult to do cost-effective analysis. I'm currently doing a retrospective multi-center analysis on the Korean use of the peripheral devices, and because the price policy is different from country to country, and it is difficult to compare the situations in different countries, and also. If we do cost-effective analysis, then the patients have different characteristics of lesions, and it is very difficult to compare devices within this study population because they have different characters. And also to say atherectomy is not cost-effective, it is a little bit unfair because sometimes without atherectomy device, we cannot succeed the procedure. So we may better select the proper subgroup in which the atherectomy device really helps. But in other studies, populations where the atherectomy does not have impact on the outcomes, maybe we should avoid the use expensive devices. But I think we need to define these groups where we have really benefits from atherectomy device. Dr. Ida, so what is your impression? You also think the Illuvia performs better than polymer-free DS?
Yes, I think so. So from the Imperial study, the primary patency at 1 year and 2 year is better in the Illuvia than the Silver PTX. So demonstrating this technology is very reliable. But one concern is rising right now because as you know, we sometimes experience the patient with halo sign and aneurysmal degeneration, as well as the pattern of the restenosis after Illuvia stent is mainly the instant occlusion. So this is a clinical issue, rising concern after Illuvia stent implantation. But anyway, the main objective is to use the Illuvia stent is to reduce the restenosis. I think that this technology is very outstanding. But this is all a similar history from the coronary artery, because reduction of the restenosis is very promising. But we experience a new issue in the clinical setting. We have to discuss more these topics. Thank you.
Yeah. So my impression is that Illuvia performs better than Silver PTX, which was also found in our retrospective study. But actually, personally, I haven't met a case where the patient had the halo sign after at the follow-up. So Is anybody who experienced this kind of complication related to Eluvia stent?
So I experienced that one case, very impressive case, because at the 1 year follow-up, we did not detect the halo sign and also aneurysmal degeneration. But after 3 years, the patient had the free from the symptom, but they have the halo sign with aneurysmal outside the blood flow, So maybe we need a more longitudinal follow-up after Eluvia stent implantation. But anyway, from the eminent study, demonstrate that no difference between the CVTLR patient with or without halo sign. We need a more discussion about this point.
Do you think subintimal, approach and assisted with the Eluvia stent may develop, this kind of problem more frequently than, intraluminal approach?
It is, yes, it is, because I think that it's coming from the injury at the medial. This is a very different point on the coronary and the peripheral. If you take a look at the IVUS finding, the thickness of the media is completely different from the coronary and the peripheral. And also injured the media is a very important factor to develop the aneurysmal degeneration. I think that it's not a specific problem in the Eluvia stent. I think that all stent and all DCB has a chance to make aneurysmal this kind of the adverse event after peripheral intervention. Thank you.
So we are conducted in Eluvia registry in Korea, and we are just now follow these patients, and maybe we can also find this kind of problem. So let me see. So any other comments?
Actually,
Dr. Roth, do you have any comments?
Yes, actually, I also implanted a lot. And when we consider the clinical scenario, most of the SFA, especially complex case, when the balloon response is very favorable, favorable means that just we can finalize with within one bailout BMS stenting. Mostly we finalize with the DCB. So when we deploy the Eluvia DES, the balloon response must be much more worse. So it means that can be associated with more aggressive balloon angioplasty, including subintimal angioplasty, and more lesion pretreatment, more calcified lesion, longer lesion, and something bidirectional approach, retrograde approach. So more injurious procedure must be associated. In the case, when we get lesson from the first generation DES, Cypher and Texas, we also experienced DES associated cytotoxicity, arteriopathy, rate stent malopposition, and the DES associated aneurysm. So despite of lower toxic dose of this paclitaxel, sometimes we, not real aneurysm, but something, little dilation of the injured site at follow-up image we can see, but really not clinically evident worrisome dilatation I could not experience yet. However, we have to observe with the longer time duration. So that is my comment on that. However, at least we can see that up to 2 years from the Imperial study compared to the current generation, at least compared to the Zilver PTS, we can say that TLR rate and the repeat PTA incidence must be lower with this Eluvia compared to the other DS. However, in my idea, at least this polymer and the D drug must be disappeared, and the 1 year, 6 later, then everything must be, similar to BMS like era, So 2 years, 3 years, 4 years, then must be not quite different with other BMS status. So with optimal medical therapy and all the our medical management, we don't know how it will be behavior up to 4 years, 5 years. So we have to see the long-term outcome. So we should make a final conclusion with longer-term outcome. But however, when you consider this drug effect and the polymer, at least this short-term and the mid-term outcome must be important to compare the efficacy of the drug device. Because when you consider this drug efficacy and the polymer efficacy, so this 2-year outcome is very, very important for our current practice.
Okay, Dr. An, let's move to atherectomy device. When you perform, jet stream atherectomy, do you routinely put a filter to protect the distal embolization?
Yes, currently some cases was a very poor distal outcome after some embolization. So after some cases, I put always some filter devices, usually embossed for some jet stream was inserted before some atherectomy. And if there are the flow limitation after the atherectomy, before the DCB, I removed some filter device, but they usually maintain the filter after full procedure usually. So I have also some question for Dr. Yang. How about the atherectomy uses in Hong Kong, and what kind of some atherectomy devices do you prefer?
Well, we in Hong Kong, thank you for the question. We are lucky we have availability of most of them. We have Jetstream, the Hawk before it got recalled. We have the Diamondback, we have all the other ones, Rotarex, all that. So I think the main limitation in Hong Kong is the cost reimbursement, because there's a patient have to pay. So, it's at the cost of the filter, the device, and the drug. So again, it's quite costly. But I agree with you, some cases are really get optimal results. So really, I agree with the way you choose is the diffuse long, lesions, calcified lesions are really great. Lesion which I think I can get away with DCB. So, do that sort of DART or RATA, whatever you call it. So that would be ideal, and maybe with spot stenting it requires. So really to reduce the number of stents it requires, especially long lesion. That's how I would ideally choose. So I think this is I agree with these. I think what we have is a great approach for these type of lesion. It's not maybe cost effective for very simple, lesion you can get with just. So I think I tend to agree with your approach. It's very practical and sort of like based on lesion characteristics. But unfortunately, in reality, that my usage of atherectomy is a bit low because of the cost issue. So yeah, so it's theoretical and in practice. So the other question I have for you to present, Dr. Ann, is that do you, if you're not sure your true lumen, you always do IVUS as well before you do Jetstream?
Yeah, I think some IVUS was a very great impact of uses of some atherectomy devices, and some reported some over the 85% of some root was intraluminal, and less than 15% was some eccentric wiring. We can some cautiously uses the atherectomy devices. So I can guide it for some uses of atherectomy more and less. So I think its imaging study was very important for some devices uses.
Dr. Chun, we have two IVUS devices in Korea available. So one is the iLab from the Boston Scientific, and we have also the Volcano system. So in your presentation, you showed the cases which were done with the Boston Scientific system. So what do you prefer?
Sorry about that. I have no experience of a volcano system. I have just only one system, the OptiCross 18.
Mhm.
So I cannot compare the two devices.
So I think the Boston Scientific system has a better resolution, higher resolution, and you can see more. But the device, even though it is 18 French, the 18 O18 biocompatible device, which is larger than the O14 system, still it has a little bit poor backup support. So if you use a Volcano system, so even though the lesion is tight lumen, you can still pass the device. But with the Boston Scientific system, it is a little bit difficult. So you need to pre-dilate the lesion a little bit in order to pass the IVUS the caster. So, but I think you can see much more with the Boston Scientific system. So, Dr. Ida, do you have any experience with the O18 IVUS system?
I think the O18 system is very good for pushability, especially for complex femoral-popliteal and the arterial region. Thank you.
They recently showed the demonstration. I experienced 60 megahertz IVUS from Boston and good resolution. And Brian, I want to correct that the IVUS in Korea cannot be reimbursed. No insurance. Japan, they can get reimbursed, but it's very expensive. And the rich area, like in Yonsei University, they more frequently use. And Goro area in my hospital, the poor area, we cannot use frequently. So we cannot use daily. Okay.
So I think our time is up. So we have to wrap up this session. I think the discussion was very fruitful and we had a good time to discuss all the issues. Thank you very much for the participating in the session. So bye-bye.